So let me briefly explain why we chose this topic, and then I'll turn the time over to Dr. Manasanch. So today we're talking about treatments available for high-risk smoldering patients. Now, if you are an MGUS patient or a standard risk patient that's smoldering, you're still welcome to be here. We want you to be here, ask your questions, and learn with us. But we specifically wanted to talk about what constitutes high-risk smoldering myeloma, what treatments are available to these patients, what are the risks of treating too early, clinical trials that are available, and the future of watch and wait, if it will always continue. These are different talking points that either Dr. Manasanch will express today or we'll be able to ask her during the Q&A. So now it's my pleasure to introduce Dr. Manasanch to you. She specializes in the treatment of patients with multiple myeloma, and she also focuses on translational research of the precursor stages of myeloma and early disease management through groundbreaking immunotherapy-focused clinical trials. So as you can see, short and sweet, but she's an incredible speaker for this topic. And with that being said, I'm going to turn the time over to you. Thank you for being here with us.
Thank you, Audrey. It's a great honor to be here. We are going to talk about a lot of current treatments and maybe future treatments for smoldering myeloma. And as you all know, I direct the early myeloma program at MD Anderson Cancer Center in Houston, Texas. So I'm just going to go ahead and start my screen sharing. So just give me a couple of minutes to get all these started. Let me see. All right. I'm just going to need a couple of seconds. Oh, okay. Give me one more second. All right, Aubrey, is everybody, are you able to see the screen all right?
Yes, looks great. Yep.
Perfect. Thank you. So we're going to talk about myeloma precursor disease, that's the monoclonal gammopathy of undetermined significance and smoldering multiple myeloma, with an update, and also talk about high-risk smoldering myeloma therapy. So first we will give a brief introduction, then we will talk about MGUS and then smoldering myeloma. So as you know, multiple myeloma is a cancer of the white cells, and the type of white cell is the plasma cell, and it originates in the bone marrow. The function of the plasma cell is to produce antibodies to help us fight infections, and you have on the right-hand side of the screen a picture of a plasma cell here, which they have a very developed something that is called the Golgi apparatus, and this is where they secrete protein. And then the plasma cells and the cells that are surrounding the plasma cells, which we call the microenvironment in the bone marrow, they change most times through genetic changes, and they become malignant, and then they can turn into multiple myeloma. And so before we have a lot of burden from the multiple myeloma, we have a couple of stages that are monoclonal gammopathy of unknown significance and a smoldering multiple myeloma. And you can see here, this is an example of a paraprotein that, you know, many of you or some of you may follow if you are on treatment. And this has the heavy chains of the paraprotein, the light chains. These are the what's called the kappa and the lambda. And this is the IgG or IgA or IgM, depending on the different types. So we start talking about monoclonal gammopathy of unknown significance. What it means is that these are patients that have very little burden of the disease. They don't have usually any symptoms, and they have M protein. So this paraprotein that we just saw in the picture, measured in the blood of less than 3 grams per deciliter, less than 10% of the plasma cell of the bone marrow in both men are plasma cells. So most of the bone marrow is healthy. There's no symptoms associated to this in most occasions. And so when we talk about smoldering myeloma and MGUS, for MGUS, like we were saying, so very little tumor burden and very low risk of progression overall. However, there's definitely some patients that do progress, and you can see here, you know, at 10 years, 10% progressed in this retrospective study that has been used as a staple for looking at patients and risk of progression. And what you can see is that the risk of progression in patients that have a smoldering myeloma is higher. So for MGUS, now talking about MGUS, most importantly, the standard recommendation is still to not treat MGUS, and also most patients with a smoldering myeloma. And the recommendation is to check blood work, maybe a 24-hour urine every few months, and watch the patient until there is progression to multiple myeloma. And if there is need for treatment, then to potentially look at clinical trials if you have risk factors for progression. So it's not all the smoldering myeloma patients, but a fraction of the smoldering myeloma patients that actually go on to do treatment on clinical trials. If you have a precursor of myeloma, either MGUS or smoldering myeloma, you're going to do a workup to find out, to rule out that you don't have more advanced disease that you need treatment. So there's some myeloma types that express less myeloma protein, so you may not have very high myeloma protein in your blood work or in the urine, but you may have some lesions in the bones. So that for that you can do PET-CT or a whole body low-dose PET-CT or a whole body MRI. You may go ahead and do bone marrow biopsy. You may do some more specialized blood work or 24-hour urine to measure the myeloma protein in the urine. So when we talk about the MGUS patients, usually these patients fit several criteria. They have an overall low risk of progression to multiple myeloma and can be followed in clinic at intervals ranging from a few months to 1 year, depending on this risk, what is the risk of progression. And there's ways to stratify these patients in the clinic that have been validated in several studies. So again, these are the patients that have low levels of myeloma protein in the blood and the urine, and low levels of these myeloma cells, or change cells or aberrant cells, abnormal cells, whatever we want to call them in the bone marrow. So the amount of plasma cells that is abnormal in the bone marrow is low. So when we look at research for MGUS patients, at MD Anderson, we have an observational study that accrues MGUS and smoldering myeloma patients. The MGUS cohort is already fully accrued. So it's 100 patients that we have already accrued, and we're following these patients to see if there is progression, and we try to find better ways to predict individual risk of progression and identify the correct patients to treat. So we have more than 225 patients right now that we are following on this study, and the first 200 patients, all the genetic analysis and what it means for progression actually is being presented actually today at AACR, which is the American Association for Cancer Research. There's a meeting.
Hey everyone, I'm not sure if it's just frozen on my end, or if you can't hear the speaker either. So just let me know. There we go. I think, okay.
Related to this, such as, some patients.
Dr. Manasanch, can you hear me?
Yeah, I can hear you.
Yeah, you just cut out. I'm not sure what happened, but your connection dropped. So do you mind sharing your screen one more time?
Oh, the screen is not being shared right now?
No, it's almost like you went on and then off.
Let me go again. 1 second. What was the last slide that you saw?
If you pull it up, I will be able to tell you.
Okay, all right. I'm almost there.
MGUS cohort is what we were talking about, that you were about to finish, that we had two.
The last slide? Or this one?
I can't see them still. You might have to.
You cannot see the slides? How strange. Okay,
let's try one more time.
Oh yeah, it dropped. How strange.
That's okay. Zoom.
Yeah, it dropped the sharing.
Mhm.
for some reason. Well, that's strange. Okay, give me 1 second.
It is. You're on the right slide though. Yep.
Okay, that's the slide.
Yep. And you were telling us that the
Okay.
MGUS cohort was full and then
Yeah, the MGUS cohort is full. Did my voice also cut off or no?
yes, it did. Yeah.
Oh, how interesting. All right. I don't know what's going on. I have good
It's
info.
okay.
All right. So the MGUS cohort is full, and we have accrued more than 200 patients to this study. What we do is we follow these patients on observation, and we do a lot of testing with them to find out about special immune characteristics or genetic characteristics that are allowing this progression so that we can do therapies for this. And so we have the results of the first 200 patients that we were presenting in the AACR, which is a meeting in New Orleans. And it's being presented, I believe, today in the American Association of Cancer Research meeting. And it's the first 200 patients on all the genetic analysis of these patients and their follow-up. And so when we talk about smoldering myeloma, again, patients have a little bit more disease burden in the bone marrow, and you can see here, so protein of 3 grams or more, or a urinary protein, myeloma protein of 500 milligrams or more. Usually this is like really 10 to 59%, bone marrow plasma cells. And again, we have here these no symptoms, but there are patients with MGUS and smoldering myeloma that can have symptoms associated to their diseases. Some smoldering patients actually, have bony aches, things like that. And then, when they're treated on the trials for smoldering myeloma, some of those symptoms improve. And there's patients also with neuropathy, and those, if they're related, those can improve as well. So, but most of the time, what it means is that, you don't have these lesions in the bones, that you don't have kidney failure, that your blood counts are usually normal. So that's what this means. But there are some patients that definitely can have some symptoms with precursor disease. And so again, with the smoldering myeloma, it's a stage between MGUS and multiple myeloma or newly diagnosed multiple myeloma, where the risk of progression is much larger. And so this is why it's a separate kind of stage in between, because of this risk of progression, it usually requires a more close follow-up. Definitely requires, advanced imaging, bone marrow, lab studies. And then there's a lot of interest in treating a smoldering myeloma because of the opportunity to delay the progression or perhaps find a cure when you're treating a disease that is less developed and when the patient has a better immune system. So there's a lot of interest to do this. There's a lot of ways to classify a smoldering myeloma, and the risk of classification, this is the risk of progression. So this is different from when we talk about a newly diagnosed myeloma patient, whether they have high risk or not, because those are patients that are maybe may not respond to treatment. Here, these are patients, this is just your risk of progression to newly diagnosed myeloma. And so depending on the category where you are, then you may or may not qualify for clinical trials for treatment. So if you are perceived to have high risk or even intermediate risk, and these are the patients that are usually targeted in clinical trials to try to stop this progression. And again, there are just many different ways to measure the risk. There's genetic markers, there's the markers in the blood, in the urine, bone marrow markers, different ones. So there's many different ways that your doctor can assess what is your risk of progression. And just a little bit of historical data. So in the past, a lot of people, a lot of physicians try to give medications to smoldering myeloma patients and try to have a response in terms of try to delay the progression of a smoldering myeloma. But these are some of the medications that were tried. So melphalan and prednisone, these are bisphosphonates that are usually given in osteoporosis. Lenalidomide, it's a first generation immunomodulatory drug. So even before lenalidomide, this is an interleukin-1 antagonist. So they tried to do these, and the results were not really great. And so this is why, for many years, there was really no, no intervention in smoldering myeloma because the medications that were tried didn't show very significant results in clinical trials. And so the first study that was a randomized phase 3 study that really showed an impact in smoldering myeloma, took only high-risk smoldering myeloma patients. They included 119 patients. And these patients were treated, half of the patients were treated with lenalidomide, and you have the treatment is here, the treatment regimen. And then 62 patients were just observed. So they basically just were followed in the clinic without treatment. And so for the patients that went on to treatment, at the end of the therapy, which was a therapy that was initially for 9 months, so 9 months of treatment, followed by 2 years. So at the end of 2 years and 9 months of treatment, 90% of the patients were in a complete or a partial response. And most of these patients had partial responses. So most of the patients, however, did respond. And when we look at the very long-term follow-up of this study, which was released in 2022, you see that this is the progression. So what we call the progression-free survival. So this means that the patients are not progressing to newly diagnosed myeloma. So you can see the patients that were treated have less progression. So you can see here, it's difficult to see, but you can see at 80 months, you can see that 60% of the patients have not yet progressed to newly diagnosed myeloma in the treatment group, whereas in the observation group, 80% of the patients have progressed. So this is a very significant difference, and this actually translated into a difference in survival. So in this study, the patients that received lenalidomide or dexamethasone, this is the PREDEX study, actually lived longer. Okay, this study was designed in 2007, so many, many years ago. It was released initially in 2013, and then this is the update from 2022 with the long-term follow-up. The problem with this study, and why we don't usually give this treatment to our smoldering patients, is because this study included a fraction of patients that were considered newly diagnosed myeloma instead of, or compared to smoldering myeloma. So we needed different new studies to look into this a little bit better. And so here in the US, with an ECOG, Eastern Comparative Group study, which is one of the comparative groups that we have, another group is SWOG. And in this, another randomized phase 3 study in high-risk smoldering myeloma, mostly with lenalidomide, without dexamethasone versus observation. And this is 182 patients. You can see the patients that went to lenalidomide and that went to observation, about 90 patients each. And you have here the treatment. Here, the treatment consisted of lenalidomide, basically until disease progression. So in the other study, the patients received a treatment for 2 years and 9 months. Here, they receive treatment basically forever. You started here, and unless your smoldering myeloma got worse, or you had toxicity, or you wanted to stop the treatment, you would just continue. And so when we look at this, at the data in terms of progression-free survival, so you can see here there's less follow-up because this is a more modern study, but you can still see that the patients that received the lenalidomide, it took longer for them to progress to newly diagnosed myeloma. So you can see here at 30 months, most of the patients have not progressed, whereas there were some here that have progressed. This is the probability of progression. So if you were on observation to progress to newly diagnosed myeloma, you had much higher probability than if you were on lenalidomide. And in this study, the survival was about the same. Again, it could be because of the follow-up, or it could be because this study, the inclusion criteria were a little bit different, and these were smoldering patients. So you may need a very long follow-up to see any difference in treating these patients. But still, lenalidomide is most of the times not seen as the ideal initial medication on its own to treat smoldering myeloma patients. So for us, still, we recommend for patients to go on clinical trial until we have some FDA approval for this indication. When we look at our program here, we focus a lot again on these two precursor stages, and we do a lot of treatments with immunotherapy. With the smoldering part of this study, what we are still accruing patients. So if any patient, there are some patients that really want to do observation, they don't want to do any treatment. So these patients can participate in the study, and also the low risk smoldering patients that are typically observed, that don't go into trials, and some intermediate patients as well. So one of the therapies that we have pioneered at MD Anderson is cetuximab, which is a CD30 antibody monotherapy treatment that we have given in smoldering myeloma. So CD38 is a molecule that is expressed by myeloma cell, and this antibody, which we could see here and depicted in this picture, basically what it does is it attacks the myeloma cell here, and then this is targeted by the immune system. And there are different ways that this can be targeted. You can see different types of immune cells that are all engulfing the myeloma cell and basically targeting it for destruction. And so one of the reasons we are pioneers in this treatment is we actually at MD Anderson designed the ISAMAR study, and this is the phase 2 single-arm study, a total of 61 patients that treats with this antibody. In the first stage of this study, we did 24 patients with monotherapy. So they just received cetuximab, and this is the treatment schedule. So all patients received 2.5 years of treatment. And it was presented in 2019, the initial results. And this is what was presented. And what you can see here, these are the patients. Each number is one patient. And again, this has been presented already. This data is well known. But what you can see here in these 24 patients is that there's a group of patients down here that don't respond very well. They have stable disease or progressive disease. Then you have a patient or a group of patients that have, 25 to 50% reduction in the myeloma protein. But then you have this group of patients here that really get very good remissions. And this is only with this antibody, nothing else, very well tolerated. In fact, so well tolerated that in this study for these 24 patients there, actually perception of the disease and global quality of life scores actually improved from their baseline to after they received 6 months of treatment. So we actually have now also completed a stage 2 of this study, which studied 6 patients. And what we did is we added to the CD30 antibody cetuximab, we added lenalidomide, but we added this only for 6 months. And the reason to add this for 6 months only was because of some of the concerns with the long-term toxicity with lenalidomide. And so this was added only for 6 months, and patients still got 2.5 years of cetuximab. And then for the initial 6 months, they also received lenalidomide. So these results with this study has been completed, and the results are going to be reported in this June. So in just like a month and a half or so, at the annual American Society of Clinical Oncology meeting in Chicago. And these are the results. These results were very good, and these results were the basis to start a phase 3 randomized study, which is called ITACA. So ITACA is this study that we have here. This is the graphical study design, and we did first, this is a sponsored study by the company Sanofi, and it's trying, what Sanofi is trying to do is get an FDA approval for the treatment of cetuximab, lenalidomide, and combination with dexamethasone for patients with smoldering myeloma. And if this study meets its primary endpoint, which is the progression-free survival, then what will happen is that the smoldering myeloma will have an FDA approval for therapy. So patients with smoldering myeloma in the United States will be able to go to their doctors and receive this treatment here. Okay, this is the treatment that is being tested. And this treatment is being tested against lenalidomide and dexamethasone, so that patients have an option to receive treatment, so that both arms at least receive some treatment. And so this study is now open at MD Anderson, and because it's a randomized phase 3 study, it's a large study with about 300 patients. And when you go on this study, when you sign up for the study and do your screening test, you don't know if you're going to go to receive this treatment or if you're going to go on to receive this treatment. But what is clear is everyone in this study is treated. And then patients are followed for toxicity and to see, what is the rate of progression in each arm. So another study that is open right now at MD Anderson that we are accruing, that is an option, is Belantamab mafodotin in high-risk smoldering myeloma. So Belantamab mafodotin is an antibody as well. So these are all immunotherapies, another immunotherapy. And you have this antibody here. There is Belantamab, that targets this protein in the myeloma cell called BCMA. And you have also something called MMAF, which is conjugated conjugated, it just means it's attached to this antibody that targets BCMA. And MMAF is very toxic. This is why you have this little, bones like a skull here. So it's toxic. So when the Belantamab or Belantamab mafodotin is incorporated in the myeloma cell that has BCMA, then it's released and it kills the cell. And what happens is that this cell can be eaten by other cells, or it can just be destroyed. It just basically like explodes a little bit and dies. So this that drug, Belantamab mafodotin, is currently in phase 3 trials in relapsed myeloma. It remains investigational. The main toxicities of the drug are low platelets and blurry vision, because this MMAF can deposit in the cornea. When it deposits in the cornea, it deposits in the most outer layer of the cornea, and it can give blurry vision. So this is one of the side effects of this drug. But other than this, the drug is very well tolerated, and it can be given to wide range of patients. So the study that we have at MD Anderson, this is the BELA study. This is an early development study. It's a phase 1. It means that we are trying to find what is the best dose for high-risk smoldering myeloma. And the main goal of this study is to find what is the dose that we can avoid eye toxicity, that we will still see activity. Because patients with smoldering myeloma have an improved immune system, especially when compared to relapsed multiple myeloma. So it is not the same to treat a smoldering myeloma patient with Belantamab mafodotin than to treat a patient with relapsed myeloma with Belantamab mafodotin. The expectation is that the patients with a smoldering myeloma will be able to have basically enhanced efficacy to this medication that is actually otherwise very well tolerated. So we did 2 groups for this study. We did a dose finding part and a dose expansion part. So the dose finding part, we've done 3 dose levels, and this study is accruing. We have already accrued to 2 dose levels, so we really don't have any major issues. So we're actually going to start accruing to dose level 3, which is going to be in May. And then after we find a dose, which most likely is going to be in dose level 3, which is what we're thinking, then we will expand, we will do another 12 patients, and then we will report the efficacy. So this is an option for patients here at MD Anderson. So in summary, if you have MGUS, really most of the patients do observation. There could be some studies in other centers for treatment of MGUS, or to try to continue the stability of MGUS as well. For smoldering myeloma, it's important to have a risk stratification, and then if your risk of progression is very high, then you could consider clinical trials for treatment. And then also the immunotherapy approaches that we have, usually when we chemotherapy, we try to reduce the toxicity, and we try to prevent a later resistance. And so these are the 2 medications that we have right now. And this is the Ithaca and the BELA study. All right. So I think we're going to go to our Q&A now. Let me go ahead and stop sharing all this.
Wonderful. Thank you so much. I'm glad we figured out that weird tech thing that happened. I still don't know what happened.
Yes, I thank you for saying something. I didn't realize we got this.
No problem. The rest of the presentation was perfectly understandable, clear. You stayed on, your slides stayed on. So thank you for such an excellent presentation. You covered a lot already. And our audience is ready to ask some incredible questions. I'm really excited to get started. Let's start with, there's so many good ones. I'm going to start with Joe's. One of the questions that he asks here is CD38 or other expressions is evident in earlier stages than smoldering myeloma, for example, MGUS. And if you could briefly re-explain just the CD38 for people who might need a refresher.
Yeah, so this is a very good question, Joe. So yeah, CD38 is expressed in the normal plasma cells, and it's also expressed in the myeloma cells, and it's in MGUS and smoldering and in multiple myeloma. So you could theoretically treat patients with MGUS with a CD30 antibody. So you potentially could. Then the other thing, like for example, the monoclonal gammopathy of renal significance. So patients that have monoclonal gammopathy of renal significance, and just for the audience, these are patients that have like very low level disease. Like they don't really have multiple myeloma because they have, let's say, they have 3% plasma cells in the bone marrow. So the bone marrow is really very healthy and they have very little involvement of an aberrant or abnormal population of plasma cells. And it's not really cancer, but these, these proteins, these cells can be producing some proteins at a low level. But even if it's at a low level, for whatever reason, these proteins are depositing in the kidneys and they're causing kidney dysfunction. Even if it's at a low level, it's causing some kidney problems. So these patients are actually treated for, with drugs that are used for multiple myeloma. So if you have MGRS, you can use any of the drugs that are used for multiple myeloma, you can use for this. Because if you suppress these plasma cells, then you will basically avoid the proteins that are basically causing the trouble in the kidney. So you can do that. If you do that, so the question is, if so, what was seen in those cases? Then in those cases, what you see is that usually you see an improvement in the kidney function. So you can definitely, any of the drugs that you use for multiple myeloma, you could use in MGRS potentially.
Awesome, thank you. I see someone asking if we can provide a list of the studies. Dr. Manasanch has very generously offered to share the slides with you, so you will be getting those via email and you can review the information that she shared with us today. A different question, just in terms of the clarifications, a clarification on terminology that you used in one of your slides. Somebody said, what is WBLDCT?
Whole body low dose CT.
Okay, so whole body low dose CT. Okay, perfect. Thank you. Okay, let's talk a little bit more about who can qualify for these trials. So Michelle's wondering if people outside of the United States can participate in the observational trial that's still accruing smoldering myeloma patients.
You can participate, but we do have to do all the testing at MD Anderson. So you would have to travel to MD Anderson. But anybody, I mean, we have patients in the United States, from other, and from other countries, but they do travel to get their testing done. And then we take research samples, and then all those samples are processed at our center as well.
And is that a sponsored study, or would it be billed to insurance?
So it's not a sponsored study. So this is a study that is supported through grants and also some philanthropy. So there's not a big company behind it right now. It's supported through our high-risk moonshots at MD Anderson, and it's supported through other grants. So this is basically, you have MGUS, and when you're newly diagnosed, whenever you are in need of an evaluation. So for example, if you have MGUS and you've already had an evaluation like last month, and it's very clear that it's MGUS, then first of all, we've already completed the MGUS cohort. But if you have a smoldering myeloma and you had your evaluation 2 years ago, and you probably want to know, have I progressed? I mean, what is the status of my bones? Then you would have another evaluation of this, okay? And so when you were having this evaluation, then we would take research samples. So the study does not pay for you to do the tests, but whenever you are doing those tests, then we will take research samples. So only whenever if your doctor says, okay, I think maybe, it's been a few years, let's check it, let's do some blood work, let's do a scan, then we would take the research samples.
Right, yeah, that makes complete sense. Thank you. Okay, slightly different question. So we know that African Americans or Black myeloma patients, they're 2 to 3 times more likely to develop both precursor and active myeloma conditions. Were you able in those studies to differentiate between how Black myeloma patients did versus their non-white counterparts?
So we do have accrual of a significant number of African Americans in our observational study, what we call also the origin study. However, we do not see that they progress much quicker. They have more of it, but the progression seems to be very similar or a very similar rate. And then what we observe also is that they do very well with treatment. So if you treat African Americans with good therapies, they respond very well to treatment and they do very well. They have very good outcomes. We do have a lot of our smoldering, in our smoldering trials, we do have a lot of African Americans that are doing treatment. They're doing for the most part, they're doing really well. So I would say that if you give African Americans the right treatment, then the prognosis usually it's good, or I would say it's on par with other races that we treat as well. And so that's what I would say. And I have not seen a difference that they progress, that the rate of progression is quicker. I would say it's very similar to the other races that we have in the observational study.
That's encouraging. Thank you. Okay, a couple questions here. They're wondering about if you can define the difference between intermediate risk and high risk one more time. How do you define one patient as intermediate and the other one as high?
So there are many different models that you can use. One of the models that we use at MD Anderson is to look at the percentage of your plasma cells that are abnormal in the bone marrow. So if you take a sample of bone marrow and you look at 100 of your cells by a test called flow cytometry that looks at all the markers outside of the cell, we can differentiate very well which ones are normal and which ones are abnormal. And if most of your cells are abnormal, like 95% or more, then that's a risk factor. If you have 90%, even though 90% seems like a lot, it actually, that means you have 10% of healthy plasma cells. And oftentimes, if you have 10% of healthy plasma cells, of all your plasma cells in the bone marrow, or 15%, that's probably enough to have even normal immunoglobulins in the blood. So, that's a very good sign. Like if you have 10% normal, patients that have higher risk of progression have 95%, 97%, 98%, 100%. They're all very abnormal, and there's very few normal plasma cells. The other thing is your immunoglobulins. So if you have very suppressed immunoglobulins, that's usually a sign that there's a risk of progression. Another sign is if you have more involvement of your bone marrow. So if you have 40% involvement of your bone marrow, so that's usually not something that stays stable for a long time. If you have very high monoclonal protein, if your M protein is very high, if you have very high protein in the urine. So the higher those numbers are. And then there are some mutations as well. So if you have, for example, certain mutations in a gene called KRAS or NRAS, those you could have a higher risk of progression as well. So there's so many different ways you can tell, if somebody, and you can look at a lot of these things together. And basically, the more things you have like this, the higher your risk is.
Thank you. A follow-up question to that. So if they know their risk, then could they know I know we can't know who's going to progress and who's not going to progress, but the risk of their progression, like the rate.
Yeah, I mean, if you know a lot of your factors like this and you have a lot of them, then most likely, most patients that have a lot of these factors within a couple of years, you will meet you may meet the criteria to need treatment for newly diagnosed myeloma. So the patients that have a lot of these factors, usually within 2 years, of diagnosis, that's when we say. However, there are always exceptions to this. There are some patients that have some risk factors like this, and they do not seem to progress. But I would say that that's not most patients.
Another question here was, why see a multiple myeloma specialist if you have precursor conditions? And I think this is one of the reasons why you want to have somebody who's aware of how likely you are to progress. You want to have somebody that's in the know of these clinical trials. So even though you might only be seeing them annually, just having that person, I think, on your team to be able to help make these complicated decisions and just be aware of what the future might bring is beneficial Do you have anything else to add on why you believe that precursor patients should see a myeloma specialist?
I mean, I think that it depends who you're seeing. I mean, if you're seeing somebody who does all types of cancers, they're probably not going to be aware of the granularity of the precursor disease states or the drugs or the trials. So I believe that in general, you should not be seeing a physician for your main decisions if this physician is not familiarized with myeloma. So if you have somebody that does very few myeloma cases every year, I don't think you should be seeing that doctor. And the reason for that is because if they don't know this disease very well, they're likely to make mistakes. So we see patients that come in and they've been told they have one thing and they have something else and things like that. So I think that you really just want to see somebody that has some experience with this. And it doesn't have to be someone that focuses on precursor disease like me, but if someone that at least knows myeloma a little bit. And so if you don't have that, you definitely need to go to a myeloma specialist, because myeloma is a complex disease. It's different than all of the solid tumors. It's very different from the leukemias. It's very different from the lymphomas. And you really need someone who knows this disease well to be able to know what to do at each time point. So I would definitely recommend that you do not have somebody who is not familiarized with this disease treat you or manage you in the clinic.
Very well said. Thank you. Lots and lots of questions here. We expected this one, but what about CAR T for high-risk smoldering myeloma?
Yeah, so this is a very interesting question. I think that this is, we're all waiting to see what are the results of this. I think that if you have an opportunity to do this and you're a good candidate, then, why not? I think you have to look very well the consent. What are the risks involved? You have to look at potentially other therapies, because I've mentioned already, that, there are patients going on, antibodies with very few side effects, who are having really good responses with very good quality of life, which potentially has less toxicity than getting, chemotherapy and, CAR T, right? So you have to just be very informed. But if you're informed and this is your decision, it's fine to do that,
Yeah, and it's exciting. I mean, you guys are asking a question that really can only be answered through clinical trials. So if you want to be a
Right.
part of figuring out the answer, please participate, right? A couple questions here about the Ithaca study. I'll start with the first one. I know you talked about the potential of in the future they being able to just ask their physicians for this kind of treatment. This is exciting. Do you see a potential FDA approval? Are we talking like 5 years?
So the study is pretty much accrued. So it will depend. I don't know when we will have this. It will depend how well the patients do or how poorly they do. It could be still maybe a couple more years or maybe more. If the patients in both arms do very well, then it will take a very long time, because the endpoint is how many patients actually are progressing, right? So if patients do very well, they don't progress because, these are smoldering patients and the both arms there's treatment. It's not observation versus something like the trials. It's treatment versus treatment, right? Or, a treatment that has been already tried against observation, and now it's treatment against potentially an even better treatment. So it could take a really long time to get those results. And so it really will depend on how well the patients on the studies do, that we can get the data out. But it may be still, I would say, probably at least another couple of years.
Yeah, this is a totally different topic, but it is interesting to see as these myeloma treatments are getting more efficacious, then that endpoint needs to maybe change in clinical trials so that we can get faster approval. But like I said, that's a whole different topic. Another question here. This is also one that we anticipated and talked about before, but one is currently participating in this Ithaca. Is that how you say it? Ithaca study, and was wondering if he could qualify for a different clinical study if the response hasn't been exactly what they were expecting.
Yeah, I mean, that's a very good question. You can do that because, well, first of all, when you participate in research, you should know anytime that you want to stop, you can stop. So let's say you're in the Ithaca study and you've been in treatment for 1 year, and let's say you randomize to lenalidomide, dexamethasone, and you have a lot of side effects, it's not working well, whatever, and you decide, okay, I don't want to do this anymore, so you can come off that study. The studies that we design, the early phase studies, they're designed so that if you have received a treatment for smoldering myeloma, as long as you meet entry criteria for high-risk smoldering myeloma, you can participate. So if you are on the Ithaca and you get a treatment and it's not working well, you come off the study. If at the time that you come off the study, you are high-risk smoldering myeloma, you can go, for example, on the Bela study that has the Belantamab. That study is designed to take patients like that, for example, so that there's another treatment option available. And there may be other studies in the US that are designed like that as well. So the large studies like Ithaca, there's another study called DETER, that is the Tumumab, another CD3 antibody with lenalidomide, dexamethasone versus lenalidomide, dexamethasone. So all these really big studies, they don't usually accept patients that have already received some treatment, but a smaller kind of concept, to try the concept to see if it works. Those studies usually will take any patients, and so you do have the option to do that if you want to.
Thank you. A question here: if the treatment of smoldering myeloma impacts overall survival?
So I think it does. We've had patients, we've had at least a portion of the patients that we have treated on trials achieve complete remissions, and some of them have remaining complete remissions for years. And so these patients were high risk smoldering myeloma, so they had some risk of progression, and and you really cannot answer that question without clinical trial. But I presented some data from from the pre-DEXA study where it said, for those patients, it definitely made a difference. And again, some of those patients could have had newly diagnosed myeloma, so it's harder to say. In the other study, the lenalidomide versus observation, the ECOG study, there was no difference in survival, but it's very early on. You probably need a very, very long follow-up to show a difference in survival in smoldering myeloma. But if you look at patients getting very deep responses, that probably has an effect, or it may have an effect. And we know that the myeloma, when it's in smoldering, it's usually a little bit less complex. The patient is better. So I believe that, there's definitely the opportunity to do that, but the overall survival may be a difficult endpoint to have in smoldering myeloma, just because it could just take 10 years to get a result, after you do the study. And then that treatment may no longer be relevant. The way things are going with treatments nowadays, after a few years, things are no longer relevant. So it could take 10 years to get an overall survival readout on a study.
Yeah, very true. Okay, let's do rapid fire to try to get as many of these questions as possible in these last, eight-ish minutes. Mary Beth is wondering if she should be concerned if she's supposed to get a new cornea and would have to take one of these eye toxic meds in the future. Before you answer that, let me just clarify the medication that she referenced to, which is Blenrep, is probably, I think, the only known, well, now it's not approved, but it was approved treatment that had such keratopathy side effects. Is this true? So it's not like common that myeloma.
It's the only one in myeloma. So just don't, first of all, I am not qualified to make the decision whether you could get it or not. You would have to talk to one of our ophthalmologists to see whether that is something that you could do, because the toxicity from Blenrep is reversible. Mm-hmm. So I don't know if, again, I don't know if what they would say, because I'm not a specialist in ophthalmology. So the first thing I would do is I would refer you to ophthalmology and ask the question, okay, can this patient, can she do this, or is this too high, too risky? And then we would have to see what they answer, because if they say no, it's the same as the other patient. She has the cornea, it's good, so I don't know what the answer would be to that. We would have to get an ophthalmologist that has experience in Blenrep and then has experience in cornea disorders to talk to us about whether we could or could not do it.
Yeah, yeah. And there's just other options too. So I
Mhm.
wouldn't if you need that procedure, definitely get it done because there's other options that you could have.
Well,
Uh,
yeah, definitely you have to get that done. Do not you have to get that done. But I mean, if you still wanted to do that study, you would have to get, good
Yeah.
input from ophthalmology. And then, yeah, you could do other things as well. I mean, you don't have to do that one. Yeah. Mhm.
All right. Phil's wondering if it's more relevant in tracking smoldering myeloma to have the light chain ratio or the Bence-Jones protein or the bone marrow. Which do you follow when you're looking at?
I look at all of them. I told you, like, I look at like 20 different things. So I look at everything. I think they are all very important and you have to look at all of them. And on their own, any of them on their own can determine that you may need treatment. So it's very important to look at all of them.
Yeah, that's why on HealthTree Cure Hub, it's a research platform that we have on our website so that you can put whether you're MGUS, smoldering, active myeloma, whatever, you can put in all of your labs, you can put in all of your doctor's notes all in the same place so that you can see the picture of what's really happening because it does get complicated. There are so many different things to track. And so we're trying to do our best to help you track them all in the same place. Okay. How often do you recommend PET scans, MRIs, or others within smoldering myeloma patients?
So I would say that if you have a smoldering myeloma, it is not unreasonable to do once a year whole body imaging, or if there's something concern, even you could do it more often than that. But I think that most people would say once a year, you could do that just to check. Or if everything is very stable, you may not need to do it. You could do it every 18 months or every 2 years. It's not a very good standard, but I would say that nobody would say that it's wrong to do once a year if you feel like this is what you need to do.
Yeah. Karen's just wondering if keratopathy side effects are indicative of increased risk of smoldering myeloma.
No,
Yeah.
not that I know of. Mhm.
Yeah, I've never heard that either.
Mhm.
Um, which is good news, hopefully.
Mhm.
Judy is wondering if well, we were talking about different risk factors, if monosomy, how do you say that?
Monosomy 13.
Yeah, thank you. If that indicates higher risk, if that's one of those high risk genetic factors.
It's not one of the ones that are the most well known. There's I think for mutations in genes, it's probably like in like KRAS and RAS genes. Then there's if you have certain translocations potentially, but not monosomy 13 so much that I know
Okay, thank you. And then one of the last questions here, are there treatments available for high risk smoldering patients outside of clinical trial, or right now is it only available inside a clinical trial?
So I don't. So as you saw, there's a study that was a smoldering myeloma with the lenalidomide versus observation. So you could potentially do that treatment. That's just lenalidomide without steroids, but you would really have to have a discussion with your doctor because lenalidomide alone is a it's very little treatment for what we consider myeloma. So if you have high risk smoldering myeloma, it depends. You would have to really have a very good informed discussion. I don't think you would be wrong to treat with lenalidomide if you cannot have access to clinical trials. Like if you just don't have access to that, if that wouldn't be wrong based on that data. So you just have to have informed decision to do that. We usually don't do that because we feel like lenalidomide is probably, we don't think it's the best treatment that we can do, and we really want to try to get something better. So, but again, if you are somewhere where trials are not accessible and you're very concerned, then you can discuss it with your doctor, and I don't think it would be wrong to do that.
Yeah, yeah, definitely. It's like the good, better, best. Like you're not wrong to do it, but are there better options that exist in clinical trials? Okay, next question essentially asks if she was diagnosed with smoldering myeloma. Now she's doing better after a trial. To qualify for a new trial, do they look at where she is currently or where she started off?
No, they would look at where you are currently.
Wonderful. All right. And then lots of more questions, but that's where I'm going to finish it up for now, just because we are running out of time. And I wanted to give you just 1 minute, Dr. Manasanch, to say anything. And thank you for being here. Thank you for this presentation. And thank you everyone for your excellent questions.
All right. So thank you so much, Audrey, and all the myeloma community at HealthTree. It's been a pleasure to be here. And then just to remember, that there's a lot you can do. I think that if you're here already in this webinar, it means that you're very aware of what you have, and you are taking all the necessary steps. If you have a smoldering myeloma, you can participate in a trial. That's probably the way to go. If not, you can also consider, you could consider Lenalidomide after a good discussion about that. And I think that's probably what we will do. If you have MGUS, just follow it, and then I would say, try to control your anxiety. If you have MGUS, most MGUS patients do very well. They never progress. So I would just worry maybe once a year when you go to your doctor, or once every 6 months if you go check blood work, but and just make sure that you have someone who knows myeloma who is, seeing you.
Wonderfully said. Thank you so much. I appreciate for all you do for the myeloma community. Thank you.
Thank you so much, Audrey.
We're going to finish up here with just a couple of outro announcements to my audience. So we will be meeting again in May. We meet every other month, but we were supposed to meet in March and then rescheduled this to April. So we're meeting again next month, which is great because I love having discussions with you guys. And we're going to be talking about clinical trials for MGUS smoldering patients. So we're going to go a little bit more into, is there clinical trials for MGUS? Is there clinical trials for intermediate risk? I know a couple of you had questions about that. And then of course the clinical trials for high risk. But I don't want you guys to just think that the clinical trials only exist for those high risk smoldering myeloma patients. What are our other options for people who are in precursor conditions? I think the amount of research being done in the precursor field is just so exciting. And I want you to be aware of it so that you can participate, continue to accelerate this precursor myeloma research. And Dr. Nisha Joseph, who's a multiple myeloma specialist, who also enjoys researching precursor myeloma conditions, is going to be speaking to us that day. So again, May 24th, 1 p.m. Eastern. And then we do have our Connect MGUS and Smoldering group. So if you want to connect with other precursor myeloma patients or caregivers in between our bi-monthly sessions, then you're more than welcome to join our Connect group. It's like social media, but off the sites of social media that we've just created it within our website. And I'll send you a link to that in the follow-up email. Other upcoming events you might be interested in tonight is our Mountain West Myeloma Community event. So that's if you live in Montana, Idaho, Colorado, Wyoming, Utah, you're welcome to join us. And we're going to be discussing minimal residual disease. On the 20th at 1 p.m. Eastern is our relapse refractory chapter. We're going to be having a discussion about how fast can multiple myeloma progress, what happens biologically when it does. And then on the 25th at 2 p.m. Eastern is our Black myeloma health chapter. We're going to be discussing different kinds of clinical trials because there's more than one kind of clinical trial with Dr. Cole. The link to sign up for any of those events and even more events I didn't mention is found at the bottom of the slide and will be included in the follow-up email. Another big thank you to our sponsors, Amgen, AbbVie, Adaptive, Janssen, Genentech, and Bristol Myers Squibb. And thank you to each of you for helping me build this MGUS smoldering myeloma community. I appreciate each of you taking the time to be here. Hope you have a great rest of your day. Thank you, everyone.